Today's discussion is going to be on Chapter 13, the pathology of the musculoskeletal system. Our objectives for today are to review the biologic response to trauma, review lifespan musculoskeletal development and physiology, overview of the musculoskeletal response to exercise, and orient to diseases affecting the musculoskeletal system. Musculoskeletal injuries constitute over 50% of all injuries in the U.S. Fractures, strains, and dislocations collectively make up half of these injuries. Annually, approximately 7 million Americans seek medical attention for sports-related injuries. Detraining results in more noticeable muscle mass decline. Studies explore differences in injury rates and muscle response to training deconditioning between genders. Variations in ligamentous laxity, muscle strength, endurance, reaction time, and recruitment time are investigated for injury prevention insights. Women have doubled injury rates during ovulation due to high estrogen levels. So tailoring training based on menstrual cycle phases may mitigate injury risk. Neuromuscular training is an effective strategy for preventing anterior cruciate injuries in female athletes. This includes proprioceptive and neuromuscular training techniques. Men have greater muscle volume increase compared to women with strength training and experience larger muscle mass losses during detraining compared to women. Common musculoskeletal disorders include fractures, dislocation, subluxation, contusion, hematoma, repetitive overuse and microtrauma, strain and sprain, and degenerative diseases. The phases of healing and the biological response to trauma begins with the hemostasis process. Blood fills the injury gap, so blood rushes to the site of the injury to begin the healing process. Initiation of the coagulation cascade leads to the formation of a clot to stop bleeding. Platelets clump together to reinforce clot formation and stability. Growth factors are released to promote tissue repair and regeneration. The generalized inflammatory reaction is that there is an immediate response regardless of injury type or tissue damage. Vascular changes include increased blood flow and vessel dilation, chemical signaling, which is the release of inflammatory mediators, and cell recruitment, which is migration of immune cells to the injury site. During the inflammatory phase, there is vasoconstriction, which is the initial narrowing of blood vessels to reduce fluid flow or prevent the spread of bacteria and toxins. This limits blood flow to the injured area. White blood cell migration, this is also termed as margination and pavementing. The process includes white blood cells, leukocytes, which migrate to the periphery of vessels. They adhere to damaged capillary walls, which is pavementing, in preparation for diapedesis. Next is vasodilation, which allows vasoconstriction to increase blood flow to vessel permeability. Chemicals like histamines, serotonin contribute to vasodilation. Diapedesis is white blood cells, example neutrophils, squeeze through blood vessel walls to reach the site of injury. Next, there is a fluid shift, which is caused by vessel permeability due to the inflammatory mediators. This affects fluid transfer into injured area, which is driven by heightened intravascular hydrostatic pressure and altered osmotic pressure gradient. Chemotaxis is the process of white blood cells being guided to the injury site by chemical signals released from damaged tissue. Example, bacteria, toxins. Phagocytosis is neutrophils, monocytes, and macrophages recognizing and engulfing and digesting the debris, including necrotic tissue and other substances at the injury site. This helps to clean up the area and promotes tissue repair. Clinical findings of acute inflammation includes increased muscle tone or spasm. Muscles around the inflamed area may exhibit increased tone or spasm as a protective mechanism. Loss of function, impairment or restriction in the normal function of the affected area due to the inflammation. Slow and guarded movements. This is where movements in the involved area are often slow and cautious due to pain and discomfort. Components of passive movement testing: spasm end feel, which is a resistance felt due to a muscle spasm when passively moving a joint. Pain before resistance is pain reported by the patient before encountering resistance during passive movement testing. Effective interventions for acute inflammation include pharmacology, use of medications such as non-steroidal anti-inflammatory drugs or corticosteroids to manage pain and inflammation. Physical therapy is beneficial, especially if surgery is not indicated or as part of post-surgical rehabilitation. It focuses on modalities and exercises to reduce inflammation, alleviate pain, restore function, and prevent complications. Bone functions. The bone has several functions, including storage. So it's the primary storage site for essential minerals, including calcium, phosphate, sodium, and magnesium. This helps maintain mineral balance and regulate levels in the bloodstream. Remodeling, which is the process of constantly undergoing remodeling, involving bone resorption, which is breakdown, and formation throughout life. This helps to maintain bone strength, repairs microdamage, and adapts to mechanical stress. Protection. Our bones help to protect our vital components of the nervous system, example, the brain and spinal cord, and our visceral organs such as our heart and lungs from injury. Support. Bones help to provide rigid internal support for the trunk, example, the spine, the rib cage, and the extremities. This helps to maintain body structure and posture and assists in weight-bearing activities. Attachment. Bones serve as attachment sites via tendons and ligaments for various soft tissue structures, including muscles. This helps facilitate movement, stability, and transmission of muscular forces to bones during physical activity. This is a review of bone structure. We have the cortical or compact bone, which is the outer layer resembling the hard candy shell of an M&M. The function is to provide structural support to the internal bone and serves as attachment points for tendons and ligaments. Then we have cancellous bone or trabecular bone. This makes up less than 20% of the overall bone mass. It consists of spongy, intermeshing thin plates, also known as trabeculae. It functions as the site of most bone activity and remodeling involved in blood cell production and metabolic processes. The bone surfaces include the periosteal surface, which is the outer surface of the bone covered by the periosteum, which is a fibrous membrane, and the endosteal surface, which is the inner surface of the bone lining the medullary cavity. This is where bone marrow is located. Bone metabolism and cells. So bones are highly metabolic and remodeling. Bone tissue undergoes continuous remodeling throughout life, involving bone resorption and formation. Osteoclasts are cells responsible for bone resorption, the breaking down of the bone tissue. Osteoblasts are cells responsible for bone formation, synthesizing new bone tissue. Osteocytes are mature bone cells derived from osteoblasts, embedded in the bone matrix, involved in maintaining bone health and metabolism. Vascularization. Bone tissue is highly vascularized, receiving 10 to 20% of cardiac output, supplying nutrients and oxygen to bone cells. Factors influencing bone remodeling include mechanical stress. Physical activities and mechanical stresses influence bone remodeling. Weight-bearing exercises and resistance training stimulate bone formation, while immobility can lead to bone loss. Calcium and phosphate levels. Adequate levels of calcium and phosphate are essential for bone mineralization. Fluctuations in mineral levels can impact bone remodeling processes. Hormonal regulation. Various hormones play crucial roles in bone remodeling. This includes the parathyroid hormone, which stimulates osteoclast activity and increases blood calcium levels. Calcitonin, which inhibits osteoclast activity and promotes calcium deposition in bones. Vitamin D facilitates calcium absorption and bone mineralization. Cortisol influences bone remodeling and can lead to bone loss in excess. Growth hormone, thyroid hormone, sex hormones, including estrogen and testosterone, influence bone growth and metabolism. Bone and hematopoiesis, host for hemopoietic bone marrow. Bones house hemopoietic bone marrow responsible for growth and development of blood cells. Unique connective tissue repairability. Bone is the only connective tissue in the body capable of fully repairing to its original state post-injury. Bone marrow function. Bone marrow serves as the primary site for blood cell production, including red blood cells, white blood cells, and platelets. It is essential for maintaining hematopoietic system function, critical for oxygen transport, immune response, and blood clotting. Adaptive nature of bone. Bone is highly adaptive. Bone can alter its properties based on mechanical demands and environmental factors. Wolff's Law governs bone adaptation and remodeling in response to mechanical stresses. Bones remodel their structure and density based on the forces experienced during physical activities. The importance of physical activity includes bone health maintenance. Regular physical activity and mechanical loading are crucial for maintaining bone health. This helps prevent conditions like osteoporosis and reduce the risk of bone fractures. Children's bone characteristics. The porosity and susceptibility to compression. Children's bones are more porous and susceptible to compression due to ongoing growth and remodeling. Green stick fractures are common in children where the bone bends and partially breaks, resembling a green stick snapping. Growth plate fractures or epiphyseal fractures are common due to the presence of growth plates or epiphyseal plates near joints, which are the sites of bone growth. The role of growth plates. Growth plates facilitate axial or lengthwise, and circumferential thickness bone growth during childhood and adolescence. Effects of aging on bone. There's a decreased bone quality, reduction in bone stiffness and strength due to architectural, compositional, physiochemical, and microchemical changes. Peak bone density is reached in the 20s and stabilizes for about 2 decades before declining. Menopausal transition in women triggers increased bone resorption or breakdown and decreases formation due to hormonal changes such as decrease in estrogen. Bone loss rates in women experience accelerated bone loss postmenopausal, losing about 1% of bone mass per year after age 35, approximately 20% bone loss by the age of 65, and 30% by age 80. Men experience slower bone loss rates, losing 10 to 15% of bone mass by age 70 and 20% by age 80. Fracture risk with aging. By age 65, both genders are predisposed to fractures, especially in the presence of comorbidities such as osteoporosis and osteoarthritis. This should be review. This is the characteristics of muscle. Muscles require significant energy in the form of ATP to function, especially during contraction and relaxation, which means they have a high metabolic demand. Muscles have a rich blood supply, vascularization, to deliver oxygen and nutrients and remove metabolic waste products. Muscles have the unique ability to shorten or contract and lengthen or relax in response to nerve signals and mechanical stimuli. Composition of actin and myosin. Muscles are composed of specialized proteins called actin and myosin. Actin are thin filaments and myosin are thick filaments. Interaction between actin and myosin generate force during muscle contraction via the sliding filament theory. Nerve endings for muscle movement. Muscles are innervated by motor neurons that transmit signals or action potentials from the central nervous system to initiate muscle contraction. Neuromuscular junction is the site of communication between motor neuron and muscle fiber. Muscle fiber recruitment and contraction. Increase in muscle fiber recruitment. During muscle contraction, more muscle fiber cells are recruited into cooperative action to generate force. The nervous system input. Muscles require input from the nervous system to initiate and control contraction. Motor nerve signals or action potentials to muscle fibers via the neuromuscular junction. Motor neuron and associated muscle fibers form a motor unit. Motor unit characteristics include fine motor control. Motor units requiring fine control may have a 1-to-1 ratio of motor neurons to muscle fibers. Large muscles, like the quadriceps, may have one motor neuron innervating several hundred muscle fibers. The effects of force production. Characteristics of each muscle type, example slow twitch or fast twitch, can be improved through specific training and exercise. Fiber type alteration. There's limitations. While training can enhance muscle fiber characteristics, it's not possible to change the inherent fiber type itself. The dominant fiber type in a person cannot be altered through training. Muscle fiber types. We have type 1, slow twitch or red oxidative. The characteristics include fatigue-resistant fibers, red in color due to high myoglobin and capillary content, high oxidative capacity, which means that it relies on aerobic metabolism. Its function Their functions are they are suited for endurance activities requiring sustained muscle contraction over time. So an example would be marathon running or cycling. Type 2, fast twitch or white glycolytic. The subtypes are type 2A, which are fast oxidative. These are bigger than type 1 fibers. They are fatigue resistant due to moderate oxidative capacity. And type 2B, which are classic fast glycolytic fibers. These lack aerobic enzymes, leading to rapid fatigue during intense activities. Their function is that they are suited for high-intensity, short-duration activities, such as sprinting or weightlifting. Distribution and characteristics. The muscle fiber distribution includes each fiber contains a combination of type 1 and type 2 fibers in varying proportions. Fiber distribution is largely determined by genetics, with the average ratio of type 1 to type 2 fibers being around 50-50. Endurance training. Individuals trained in endurance activities, example long distance running, swimming, typically have higher proportions of type 1 fibers. High intensity training. Individuals trained for high intensity, high speed activities, example sprinting or powerlifting, generally have a greater proportion of type 2 fibers. Which type is type 1 and which is type 2? Types of injury. There's a number of different types of injuries that can affect muscles. First is a severe infection. Injury resulting from severe infection can affect muscle tissue. Transection is complete severing of muscle tissue, often resulting from trauma or a surgical procedure. Contused or strained. Contusion is a bruising of muscle tissue due to direct impact or trauma, where strain is overstretching or tearing of muscle fibers, often due to excessive force or overuse. This is important to understand that muscle tissue, when overstretched or torn, is considered a strain. Stages of muscle healing include hemostasis, which is the immediate response to injury involving blood clotting to stop bleeding. Hematoma formation and inflammation, which usually occurs between 24 and 48 hours. This is the accumulation of blood at the injury site, leads to inflammation, and is characterized by swelling, pain, and heat. Phagocytosis is the removal of cellular debris and damaged tissue by immune cells, or phagocytes. Myosatellite cell activation. Activation of myosatellite cells, also known as satellite cells, which are dormant muscle stem cells to initiate muscle repair. Myofiber regeneration. Myosatellite cells differentiate and proliferate to form new muscle fibers, repairing the damaged tissue. And lastly, tissue remodeling, which is maturation and remodeling of newly formed muscle tissue to restore function and structure. Each stage of muscle healing is crucial for the restoration of muscle function and the integrity after injury. Sarcopenia is an age-related condition characterized by loss of muscle mass, strength, and endurance, accompanied by changes in the metabolic quality of skeletal muscle. Characteristics: this involves reduction in muscle mass and/or function, impairments of muscles' capacity to regenerate and repair. Muscle mass declines at a rate of 4 to 6% per decade, starting around age 40 in women and age 60 in men. Greatest decline occurs with inactivity, acute illness, and after age 70, approximately 1% loss per year. Females are more vulnerable to lean tissue loss, but muscle strength can be preserved through exercise into later decades. The etiology, it is multifactorial, involving changes in muscle metabolism, endocrine changes such as declining testosterone levels, nutritional factors, including inadequate protein intake, and mitochondrial dysfunction and genetic factors. It is unclear how much loss of muscle function with aging is inevitable versus influenced by factors like nutrition, hormonal changes, and neurologic or immunologic dysregulation. Decreased causes of muscle function loss include decreased total number of muscle fibers, reduction in muscle fiber size or atrophy, impaired excitation, contraction coupling mechanism, decreased recruitment of high threshold motor units. Challenges and interventions. Sarcopenia poses significant challenges to maintaining muscle health and functional independence in aging populations. Interventions such as exercise, particularly resistance training, and nutritional support, specifically adequate protein intake, are crucial for mitigating the effects of sarcopenia and preventing muscle mass and strength, for preserving muscle mass and strength. Sorry about that. Clinical implications of muscle loss include metabolic disorders. Loss of muscle mass contributes to age-associated decreases in basal metabolic rate associated with metabolic disorders such as type 2 diabetes mellitus and osteoporosis. Decreased muscle strength and activity levels can cause decreased energy requirements in aging adults. It contributes to loss of muscle function and subsequent muscle weakness. Impact on activities of daily living, or ADLs. Muscle atrophy and weakness implicate difficulty in accomplishing ADLs. Impaired abilities include rising from a chair, climbing stairs, carrying groceries, etc. Slow gait speed, impaired balance reactions, and increased risk of fractures. Interventions include exercise. So appropriate exercise can alter, slow, or partially reverse age-related physiologic changes in skeletal muscle. Skeletal muscle adaptations in response to strength training in older adults include progressive resistance training or high-intensity training. An example is 2 to 6 sets of 8, repetitions at approximately 80% of one's 1 rep max. Addressing muscle loss through targeted exercise interventions is crucial for preserving functional independence and quality of life in the aging adult. Here we're going to talk about articular cartilage. So functions of joint capsules surround and stabilize the joints. Joint capsules envelop and stabilize the joint, providing structural support. Also, shock absorption and friction reduction. It helps absorb shock during joint movement, reducing impact on the joint structures. Also, decrease in friction between joint surfaces, facilitating smooth movement. Preferential response to compressive forces. Joint capsules exhibit better resilience to compressive forces compared to torsional forces. Avascular and aneural nature. Joint capsules lack blood vessels and nerves, contributing to their low sensitivity to pain and limited healing capacities. Nourishment and lubrication. Movement of the joint pumps synovial fluid within the joint capsule, facilitating lubrication and nourishment of the cartilage surfaces. Immobilization can hinder this movement, potentially compromising cartilage health and joint function. Degenerative changes in articular cartilage. With aging, articular cartilage may undergo degeneration, thinning, or damage, leading to loss of water content. These changes contribute significantly to the increased incidence of osteoarthritis with age. By age 60, approximately 80% of the population may show evidence of cartilage changes associated with osteoarthritis. However, only about 15% of individuals may experience symptomatic osteoarthritis. New interventions and treatments. Knowledge of these changes has led to the development of interventions such as glucosamine chondroitin supplementation and joint viscosupplementation for osteoarthritis management. The importance of joint protection and education, and regardless of symptomatic presentation, educating adults about joint protection and preventative measures is crucial. Physical therapy plays a significant role in educating patients about joint protection strategies to prevent or manage osteoarthritis or maintain joint health. Composition and function of fibrocartilage. The composition. Fibrocartilage is composed of white fibrous tissue, providing toughness and flexibility, along with cartilage tissue, which imparts elasticity. It is typically found in structures such as ligament insertions, meniscus, and intervertebral discs. In the meniscus, the peripheral borders are vascularized, facilitating the repair process. Fibrocartilage structures absorb and disperse multidirectional forces, providing stability and shock absorption to the joints. Nourishment of the fibrocartilage is facilitated by movement, which helps in the milking of fluids to provide essential nutrients and maintain tissue health. Synovial joints are lubricated by synovial fluid, which helps reduce friction and wear on the fibrocartilage surfaces. In structures like the intervertebral disc and pubic symphysis, trabecular bone provides support and contributes to overall joint stability. Injuries to fibrocartilage can occur due to trauma or degenerative processes, leading to issues such as tears or degeneration. Articular cartilage undergoes biochemical and structural changes with aging, leading to decreased tensile strength and altered composition. These changes increase the susceptibility to conditions like osteoarthritis and cartilage degeneration. Aging may also affect other joint structures, including subchondral bone and synovium. Deterioration of the subchondral bone and atrophy of the synovium can contribute to joint dysfunction and exacerbate osteoarthritic changes. A well-regulated exercise program, when performed correctly, does not typically produce or worsen symptoms. In fact, appropriate exercise can have a beneficial effect on joint health, potentially improving symptoms associated with osteoarthritis. Trabecular bone tissue is porous and spongy material found in the epiphyses and metaphyses of bones, as well as in the vertebral bodies. It is a hierarchical structure composed of hard and soft tissue components, contributing to bone strength and resilience. Characteristics and functions of ligaments. They provide attachment and stability. Ligaments attach bone to bone, providing stability to joints and limiting excessive movement at end ranges. While ligaments themselves do not possess contractile capability, they can become thicker and stronger as a positive adaptation to training or stress over time. Ligaments are hypovascular, meaning they have limited blood supply, but they are highly innervated, providing sensory feedback to the central nervous system. Ligaments receive nutrients primarily from the synovial fluid within the joints, since they do not have a designated blood supply. Ligaments are most frequently damaged through sudden twist or excessive forces applied to a joint, leading to sprains or tears. So an injury to a ligament would be called a sprain, where the injury to a muscle is considered a strain. Ligament sprains and healing potential. Ligament sprains can heal to approximately 97 to 98% of their original strength, depending on the severity of the injury and the effectiveness of rehabilitation. Some ligaments, such as the medial collateral ligament, or MCL, have relatively good capacity to heal on their own with conservative treatment, while others, like the anterior cruciate ligament or ACL, typically require surgical intervention due to limited natural healing ability. A sprain refers to trauma, overstretching, or tearing of a ligament, which can occur to a sudden twisting, impact, or excessive force applied to a joint. Common symptoms of ligament sprains include pain, swelling, bruising, and loss of motion in the affected joint. These symptoms may vary in severity depending on the extent of the ligament damage and associated injuries. Tendons connect muscles to bone. They are highly elastic and withstand high tensile forces. They have parallel orientation for smooth movement, limited blood supply, and is nourished by synovial fluid in the surrounding tendon sheath. A strain would be caused by overstretching and excessive tensile force. Clinical manifestations also include pain, muscle spasm, muscle weakness, swelling, and loss of function. Physiological differences in exercise, adults versus children. In adults, cardiovascular system, they have larger heart size and stroke volume compared to children, higher maximum oxygen uptake or VO2 max due to greater cardiac output and oxygen delivery in muscles. In the muscles, as we age, we experience sarcopenia, which is age-related muscle loss, leading to decreased strength, endurance, and muscle mass, and reduced metabolic rate due to loss of muscle mass. In the joints and connective tissue, there is an increased stiffness and decreased flexibility, diminished proprioception, especially in knees and ankles. Within articular cartilage, there's degeneration and thinning leading to reduced shock absorption. Within our tendons and ligaments, there's decreased tensile strength, increasing susceptibility to injury. Within our bones, there's decreased bone mineral density, BMD, increasing the risk of fractures. Children, on the other hand, have smaller heart size and stroke volume compared to adults, lower maximum oxygen uptake or VO2 max due to smaller cardiac output. Within their muscles, strength training considerations depend on the maturity level and the ability to follow instructions for safety. Joint and connective tissue generally are more flexible and have better proprioception. Within the articular cartilage, it is more resilient and thicker compared to adults. Tendons and ligaments are more elastic and less prone to injury compared to adults. Growing bones with higher bone mineral density compared to adults, but still susceptible to fractures and injuries. Considerations for strength training in children. Strength training in children should be supervised and tailored to their developmental stage and their abilities. Focus on proper technique, safety, and gradual progression to avoid injury and promote motor skill development. Resistance exercises should be age appropriate, emphasizing body weight exercises, coordination drills, and functional movements. Adults should focus on maintaining cardiovascular fitness, muscle strength, and joint mobility through regular exercise. Children should engage in age-appropriate physical activities to promote overall health, fitness, and motor development. Both adults and children benefit from exercise programs designed to address specific physiologic needs and promote long-term health and well-being. Musculoskeletal through the lifespan, participation in regular exercise programs may reduce the amount of functional decline associated with aging. Endurance training helps to maintain and improve cardiovascular function, reductions in risk factors to improve health status, and strength training for adults versus children. Inactivity, whether due to bed rest or sedentary lifestyle, can have significant physical and physiological consequences on the body. Here are some of the key effects. Rapid physical and physiological changes. Within days of inactivity, the body begins to adapt to reduce physical demands. Cardiovascular function decreases, muscle strength and flexibility decline, and bone density decreases. Reversal of these physiological changes can take months of regular physical activity. It requires sustained effort and consistent exercise to regain lost fitness and functional capacity. Bed rest can have profound effects on physical work capacity and overall health. 3 weeks of bed rest can result in more significant declines in physical fitness than 3 decades of aging. Muscle atrophy, cardiovascular deconditioning, bone loss, and metabolic changes are accelerated during prolonged bed rest. Side effects of inactivity include muscle atrophy, cardiovascular deconditioning, bone density loss, metabolic changes. Regular physical activity is essential to maintain cardiovascular health, muscle strength, bone density, and overall functional capacity. Even short periods of inactivity can lead to rapid decline in physical fitness and health. Incorporating exercise into daily routines can help mitigate the negative effects of inactivity and promote long-term health and well-being. Effects of aging on musculoskeletal tissue. As individuals age, several changes occur in the musculoskeletal system, affecting tendons, ligaments, muscles, cartilage, and joints. Within the tendons, ligaments, and muscles, there's reduced water content and altered collagen structure in tendons, ligaments, and muscles that contribute to increased stiffness with age. There's also a loss of muscle mass, also known as sarcopenia, and strength are common age-related changes. Articular cartilage undergoes biochemical changes, including decreased water content and altered composition of proteoglycans and collagen. This leads to reduced tensile strength and increased susceptibility to degenerative joint conditions like osteoarthritis. Deterioration of subchondral bone beneath the cartilage and synovium, the lining of the joint capsule, occur with aging. These changes contribute to joint stiffness, pain, and reduced mobility. Exercise can be beneficial for joint health in older adults. Joint symptom management. A well-regulated exercise does not worsen joint symptoms and may actually improve them. Exercise helps maintain joint mobility, strengthen supporting muscles, and improve overall function. Exercise plays a crucial role in managing osteoarthritis by reducing pain, improving joint stability, and enhancing joint flexibility. Specific exercises targeting muscle strength, flexibility, and aerobic fitness can alleviate symptoms and slow disease progression in osteoarthritis. Low-impact activities such as swimming, cycling, and walking are gentle on the joints and beneficial for overall fitness. Strength training, specifically resistance training, can help maintain muscle mass, protect joints, and improve joint function. Osteoclast activity involves breaking down bone to facilitate rebuilding. Simultaneously, osteoblastic activity builds up new bone to replace what has broken down. Effects of immobilization and weightlessness on bone. Complete immobilization and weightlessness lead to rapid bone resorption. Bone mass can recover when activity resumes, but reversibility is not guaranteed. Immobilization also affects collagen, ligaments, and the musculotendinous junction, reducing range of motion. Increased activity levels are associated with higher bone mineral density and positive changes in collagen and ligaments, applicable to children as well. Some conditions affecting bone health in aging adults include osteopenia, osteomalacia, and osteoporosis, and impact bone mineralization and overall bone health. Aging adults, especially postmenopausal women, are at increased risk of osteoporosis-related fractures. Musculoskeletal differences between children and adults. Within the bones, children have more porous and susceptible to compression and green stick fractures, where adults experience age-related loss in bone mineral density, leading to conditions like osteopenia and osteoporosis. Within the muscles, children's muscle strength can be influenced by growth and maturation, and strength gains often from improved coordination and neuromuscular recruitment, whereas adults experience age-related loss in muscle mass and strength known as sarcopenia due to factors like decreased protein synthesis and hormonal changes. Strength training involves resistance exercises aimed at increasing muscle strength, power, and endurance. They can be beneficial for both children and adults to improve overall musculoskeletal health and function. Endurance training focuses on activities that improve cardiovascular endurance and stamina. This includes activities like running, swimming, and cycling, aimed at improving the efficiency of the cardiovascular system and enhancing endurance capacity. Muscle function involves strength, which positively correlates with muscle fiber diameter, where hypertrophy, which is an increase in fiber size, leads to greater strength, while atrophy, which is a decrease in fiber size, results in reduced strength. Strength represents the force output generated by a contracting muscle. Strength training exercises such as resistance training are essential for improving muscle strength. Endurance refers to the ability of muscles to work continuously over an extended period of time without fatigue. Endurance can be measured by assessing how long a muscle or muscle group can sustain submaximal or repeated contractions. Endurance training, including aerobic exercises, helps enhance the muscle's ability to sustain activity over prolonged periods. Exercise recommendations include a well-rounded exercise program that should include components targeting aerobic fitness, muscle strength, and flexibility. Aerobic exercises include cardiovascular health and endurance. Resistance training focusing on muscle strength and hypertrophy enhance overall muscle function and performance, where flexibility exercises help maintain joint mobility and reduce the risk of injury. Strength training and strength gains. Strength gains in all populations. Adequate strength training programs can lead to significant strength gains across all age groups, including older adults. There's enhanced neuromuscular activation, which occurs during the initial 8 weeks of training, contributing to early strength gains. Subsequent weeks of training result in an increased fiber density and hypertrophy, further enhancing strength. Strength training does not typically increase maximal oxygen uptake, or VO2 max, beyond normal levels. Individuals generally attain the same maximal VO2 before and after strength training. Sarcopenia, which is the age-related loss of muscle mass and function, can be prevented, reduced, and even reversed with appropriate strength training programs. Prescriptive strength training programs emphasize gradual, progressive, and high-intensity resistance exercises for both upper and lower extremities. High-load, low-repetition exercises are particularly effective in promoting muscle hypertrophy and strength gains. Strength training, therefore, plays a crucial role in improving muscle strength and function across various populations, offering benefits such as increased neuromuscular activation, fiber density, and hypertrophy, while also helping prevent and reverse age-related muscle loss. Strength training effects in aging. There's evidence that strength training has a positive effect on the aging skeletal muscle. Studies indicate that strength training in the older adult produces substantial increases in strength, mass, power, and quality of skeletal muscle, can increase endurance performance, normalize blood pressure in those with high to normal values, reduces insulin resistance, decreases both total and intra-abdominal fat, increases resting metabolic rate in older men, prevents the loss of bone mineral density with age, reduces risk factors for falls, and may reduce pain and improve function in those with osteoarthritis in the knees. Endurance training and oxidative capacity. Endurance training aims to improve stamina, which refers to the duration a person can sustain strenuous activity and aerobic capacity, typically measured as VO2 max. It involves exercises that place a sustained and high metabolic demand on muscles. The effects on oxidative capacity. Endurance training leads to an increase in the oxidative capacity of all muscle fiber types. Oxidative capacity is a measure of the muscle's maximal ability to utilize oxygen, typically expressed in microliters of oxygen consumed per gram of muscle per hour. Higher oxidative capacities indicates healthier muscles, as they are more efficient in utilizing oxygen for energy production. Endurance training is essential for improving stamina, aerobic capacity, and overall cardiovascular health. By increasing the oxidative capacity of muscles, individuals can enhance their ability to sustain prolonged physical activity and promote overall muscle health. Endurance exercise and aging. Reversal of decline in physical conditioning. Endurance exercises can reverse the decline in physical conditioning associated with aging. An endurance training program, even with relatively modest intensity, has the potential to reverse 100% of the loss of cardiovascular capacity in healthy older adults, bringing them back to levels of aerobic power similar to a young adult. Endurance training targets improving stamina, measured as the duration a person can sustain strenuous activity and aerobic capacity, typically assessed by VO2 max. It imposes a high metabolic demand on the muscles and increases the oxidative capacity of all muscle fiber types. In middle-aged adults, the decline in cardiovascular capacity is attributed to reduced plasticity of heart muscle. Improved aerobic power following endurance training is directly linked to peripheral oxygen extraction, indicating the muscle's enhanced ability to utilize oxygen. Aerobic exercise enhances functional capacity and reduces the risk of developing type 2 diabetes in older adults. However, aerobic endurance training must meet certain criteria, including frequency, intensity, and duration, to effectively develop and maintain cardiovascular fitness in healthy adults. Here you can see exercise prescription formulas. Strength training guidelines. For healthy individuals and those with chronic diseases, the frequency should be 2 to 3 times per week. Perform exercises through full range of motion. Aim for up to 15 repetitions per set. Include 8 to 10 different exercises targeting major muscle groups. And adjust weight to develop and maintain muscle mass, endurance, and strength. For very old adults, over 85 years old, the frequency should be 2 to 3 times per week, with a target of 40 to 60% of heart rate at rest. The duration should be performing exercises for 20 minutes, completing 2 to 3 sets of 8 to 12 reps, increase weight by 5% and decrease repetitions when 12 reps can be completed without difficulty. Cardiorespiratory and muscular fitness training guidelines for healthy adults, 3 to 5 times per week at an intensity of 55 or 65% to 90% heart rate max, or 40 to 50% to 85% VO2 max. Duration should be between 20 to 60 minutes continuous or 10-minute bouts throughout the day. General exercise guidelines. Exercise programs should be designed to induce the desired training effects per patient. Consideration of any existing medical conditions or health concerns that may impact the patient's ability to exercise safely and effectively is important to recognize. Tailoring the exercise program based on the optimal frequency of sessions per week, intensity levels appropriate for the individual's fitness level and goals, and the duration of each exercise session. Adjusting the exercise program according to the stage of healing for any injury or surgical procedures that the patient may be recovering from. Aligning the exercise program with the patient's specific goals, whether they are focused on improving strength, endurance, flexibility, or addressing particular functional limitations, is also important. Also, to recognize the unique considerations for different age groups, including pediatric, adult, and geriatric populations, such as developmental stages, musculoskeletal maturity, and age-related changes in physiology and fitness capabilities. And that is our lecture.